We have two presentations today. The first one is going to be presented by Dr. Tolani, and I would like to invite Cathy Greff to please introduce him. Over to you, Cathy.
Thank you very much, and good evening, everyone. It's my pleasure to introduce you to Dr. Musliu Tolani, who will be giving today's lecture on clinical trial preparation, protocols, trial development, design, and operational determinants. Dr. Tolani is a lecturer and consultant urologist at ABUTH and a lecturer at ABU. His research interests include evaluating the quality of care and survival outcomes among prostate cancer patients in Nigeria, development of a community-based prostate cancer early cancer detection program, and other interventions to improve clinical outcomes of prostate cancer patients in Nigeria. So welcome, Dr. Tolani, and thank you very much for giving today's lecture.
Yeah, so good evening, everybody, and I'm delighted to be here today to give the talk on a clinical trial presentation. Musliu Tolani. So we'll be talking today about this topic in three sections. In the first section, we'll talk about clinical trial designs. In the second section, about sample size as well as study endpoints. And in the third section, on developing case report forms and on patient recruitment and retention. I mean, this will be a pretty abridged version of what I've prepared, within bearing the limitations in terms of. All right, so the first section. We'll make this a case-based discussion, and we'll take this scenario of the spring trial. This is an extract from the abstract of the methodology. Children aged 5 to 12 years with sickle cell anemia who had abnormal transcranial Doppler velocities were recruited for this study. For randomization, they used block sizes of 4 stratified by sex and site. And allocation was concealed from all but the participants and statisticians. Participants were assigned in 1-to-1 ratio to different doses of oral hydroxyurea, and the primary outcome was initial stroke or TIA. What I would like us to reflect on now is what makes this particular study a clinical trial, if nobody called it a trial for us, and what kind of trial design was used, and what type of randomization was used. As we go along, we'll try to answer this set of questions to this particular exercise. So, I mean, what is a trial in the first case? NIH defined trials using 4 major criteria: that the study must involve human participants, and the study should have an intervention. An intervention must be by prospective assignments. That the study is designed to evaluate the effect of an intervention, and then the effect that is evaluating itself must be health-related. If we can say yes to these 4 questions, we can say that the study is a trial. Now, let's reflect on this and look back at the initial example. We'll see that the human participant, children between ages of 5 to 12, and we'll see that the intervention was really hydroxyurea in low dose versus moderate dose, and the patients were actually selected prospectively. And the effect that I projected as a primary outcome was initial stroke, which are actually health-related biomedical outcome. Just to state further, it does not mean that all patients recruited for trial all participants recruited for trials must be patients, because elderly participants can also be recruited, especially in some behavioral studies. And so a trial is not just about testing drugs. It can also be about testing medical or surgical procedures or devices, or about even looking at behavioral outcomes. And again, a trial must not be a comparative study, because they are single-arm trials. And it must not just necessarily evaluate physical health, as quality of life can be evaluated as part of patient-reported outcome, as well as adherence can be evaluated as part of feasibility outcome. However, what we do not define as trials includes secondary analysis on biological samples or basic health information, or we have outcome measures, and our major aim in that particular study is to refine or validate the measures rather than actually testing outcomes using those measures. NIH has made this simpler by actually putting this set of questions in an NIH clinical trial questionnaire as defined in the link posted on the slide. Now, trial can be classified in various, according to various types. Based on intervention assignment methods, we can say trials can be randomized or non-randomized. Non-randomized trials can also be sub-classified based on the randomization methods. The most common we know is the simple randomization, which is commonly used for large trials too, and could be by methods of coin toss or drawing a lot. But recent, a lot of residents in Nigeria do use SPSS to randomize into, to generate a random number, random numbers to assign patients into group. And those that engage in trials also have REDCap, and then we've also used REDCap module to actually randomize patients into groups. In the past, manually, a random number table can be used to read off, to assign patients into group based on digits of 0 to 9. And you just have to divide these digits into two groups and read it off from random pages of the random number table. Block randomization is used for smaller trials. Practically, it could actually be in blocks of 4. That means that you look at two groups in 4 letters or blocks of 6. And that determines the sequences one can assign to patients for this randomization. Eventually, a random selection of one sequence, as stated here, is allocated. These are as AABB or up to BBAA. And for each particular sequence, the patients are assigned based on the order of the groups in the sequence until the sample is completed. The advantage of this over simple randomization is it ensures that we are regularly checking that randomization sequence, the randomization of patients at intervals to ensure that there's an equal assignment to both patient groups. For cluster randomized, on the other hand, randomization is at the group level, and we'll probably look at examples to project this. So if you look again back at the first example, you see that randomization was done in blocks of 4 to assign patients. We'll probably say this is block randomization, but it's a different type of block randomization because they also further stratified the patients by sex and another criteria, making it some form of permuted block randomization for that particular example. Based on assignment method, the other type of randomization is a non-randomized trial, not so common, but allocation could be based on preferences of either patients or provider or based on study location. It could just be based on trying to look at the chronological order and compare pre-post. Really, this type of trial is what is used in most feasibility studies and implementation trials. And comparison is still possible in non-randomized trials as your collected data can be looked at, reclassified, and matched based on disease or patient characteristics like age or disease severity, or by time. So we can actually look at what is presently happening as our standard of care and then introduce a new intervention, look at pre-post to see whether there's a change at any point in the intervention. Now, trials can also be classified by level of blinding. And if you look at all these classification schemes, it can actually be joined together. For instance, you can actually have a randomized, double-blinded or single-blinded trial. By level of blinding, trials can be classified as either blinded or open label. And the blinding can be single, in which case it focuses on the participants. It can be double, in which case it includes the investigator and the participants, or triple, where the statistician is also blinded. Both the participants and the investigator know, and other people know the type of intervention given in open label trials. Just looking at this and reflecting back at the previous example, we'll actually see that the statement made here was about allocation concealed from all but the pharmacist and the statistician. If you look at this again, you'll see that that means the patients were blinded, the investigators were blinded, but the statisticians were not. So this overs to at least being a double-blinded trial. Okay, so while looking at blinding, I mean, the type of blinding one does also depends on the type of trial it is. For drug trials, one could probably compare the drug with the active ingredient against the placebo. For device trials, one can probably compare another identical device to blind the device operator or blind the assessor by just using independent raters to review a video recording of the use of the device. Or for behavioral trials, blinding also the outcome assessors as well as the statisticians. So of course, the patients, if included, is blinded in most of these. For the investigation, the easiest way to blind is by using unique participant identification number while you are running the trials to maintain anonymity at every stage in time for the trial. Now, just look at the text in green in this trial, this cheetah trial. We did this about 2 years ago, a multi-center study, including Nigeria, and hospitals were randomly assigned to current practice. Hospitals were randomly assigned to current practice versus intervention. And if you look at this trial design and reflect on the types of randomized trials we talked about, this will be called a cluster randomized trial. Again, we'll just want to reflect again on the blinding we talked about. And if you look at the other statement again, it was not possible to mask site investigators in this cheetah trial, nor the outcome assessors, but patients were masked to the treatment allocation. Looking at this type of blinding, we'll see that patients were blinded, but others were not. And this can actually qualify as a single-blinded trial. So a cheetah trial is a single-blinded trial. Based on the structure of administering the intervention, trials can be classified as parallel or crossover. Parallel is one of the most common we do because, it just involves comparing two separate groups with different interventions. And the interventions are given at the same time, and then after we finish, we compare outcomes between groups. This is different from crossover, where a single patient receives more than one intervention. It actually starts with a particular intervention, then the washout period, then the next type of intervention. So within individual comparison is done for this kind of trial as patient serves as its own self-control. There are more complex types of trials based on the structure, and examples include the step wedge trial, where trials are rolled out. The interventions are rolled out across clusters over time, and all clusters another type of trial again is the factorial trial. In the factorial trial, multiple interventions are tested at the same time. There's a trial we are presently running now, Penguin trial. It's a 2x2 factorial trial. We are using two interventions. We are giving medical air on one hand, and then also trying to look at the effect of chlorhexidine and mouthwashing, reducing the rate of surgical site infection. And that would mean for you to look at two interventions, it will be comparing two groups. It will be comparing the possible number of combinations of those two interventions. And we can get outcomes, including what's the effect of using both together, the effect of none being there, or the effect of the interventions being singly introduced. Yeah, so this schema shows a trial, MAPIT, done in Nigeria across 30 primary care centers, in which patients, PHCs sequentially crossed over from the standard of care, which is the hypertension program only, through a training period, marked TR on the schema in the red box, to hypertension plus practice facilitation, which is actually the new intervention being given, marked PF. If you look at the schema again, you see that this is in blocks of 5, and we'll say that perhaps even though there are actually 30 PHCs, 30 clusters, but in the trial itself, we probably have 5 sub-clusters and I mean used for this trial. And for this trial, we also see that it's an example of some form of crossover trial because patients crossed from SD following a training to PF. And again, as a stepwise trial, one of the things needed to calculate sample size is knowing the number of periods. And for you to know the number of periods, you need to know the number of crossovers. And if you look at the number of steps, it looks as, I mean, it's 5 here. So number of periods is calculated by the number of steps plus 1. So number of periods here will be 6 because, I mean, this particular data is important while calculating sample sizes for stepwise trial. Based on the objective of the trial, feasibility trial I mean, is an example and is majorly done for operational purposes and assesses the practicability of future large-scale definitive trials. So essentially, implementation outcomes or feasibility outcomes are looked at in this trial. Pragmatic trial does not really affect the structure of the trial per se, but I mean, a lot of people talk about it now because it encourages real-world applicability of whatever data one is collecting, the trial context to the real-world situation, because it's not, I mean, the trial condition is not ideal, but made to be more applicable to the general setting. So things that can be done to make trials more pragmatic includes not making the inclusion criteria so strict or excluding everything possible, which will limit recruitment. Also, having flexible protocol is important in order to achieve pragmatic trial. So this is also another example now of which trial also done within Africa. The study in design actually involved multiple patient engagement. And after that, it was decided that placebo will not be beneficial as it will deprive children of potentially life-saving medication. If you just look at this only, it will mean that it's a single-arm trial. And of course, going further, trying to look at the purpose of this trial, you see that it was to obtain a critical pilot data and endpoints were feasibility and benefits. Now, this is particularly important, especially when you are looking at implementing from an implementation research perspective, because this combines both implementation feasibility endpoints as well as implementation or effectiveness endpoints. So we can actually call this trial some form of an hybrid implementation effectiveness trial. I wouldn't dwell much on this slide, but I mean, part of trial outcomes that is assessed in a feasibility trial include recruitment rate, dropout rate, adherence rate, and as well as time to completion of questionnaire, because I mean, we need to know all this because before we scale out and do a definitive large-scale trial. And there are various forms of biases in trials, and biases are basically systematic errors during the course of a trial. It really affects the validity, reliability, and generalizability of results of trials. And it will occur during the design as a selection bias or an allocation bias. And ways to address selection bias is by randomization, and allocation bias by blinding those that are really allocating the intervention itself, as well as centrally allocating the patients to groups. Bias can occur during the conduct of trials, as in performance bias for an unequal ongoing care to patients receive, other than that, rather than intervention being assessed. And one way to address it is to make sure everybody receives the same thing by using a standardized protocol. Ascertainment bias is really in measurements, either it being subjective or being inconsistent. And the best way to handle this is by using objective tools and or using similar validated tools across the groups that are being in the trial. Bias can also occur in data analysis, especially in handling dropout rate between groups, because it's not everybody that starts a trial that finishes it. And that's where the concept of intent to treat analysis comes, in which even though patients might drop out at some point or switch to another group, you still analyze patients according to the initial randomization, like protocol analysis, where patients are actually analyzed according to the protocol they received, excluding those that didn't receive things under that same protocol. Analytical bias, of course, especially with the way statisticians we handle missing data or outliers, and it can actually make the results of data skew towards one point. And blinding statistician is important to address this, as well as having a preformed statistical analysis plan before the study begins. There's also a lot about dissemination, bias during dissemination, with a lot of negative trials not being published, and some of this can be, addressed by encouraging publication of negative trials, and also registering trials in prospective trial registries. I mean, there are a lot of them, clinicaltrials.gov. I think Nigeria also has the Nigerian clinical trial data registry that can be employed to document some of these study protocols. So we'll go to the next section. Now, this section will be talking about trial protocol development. We'll really dwell on sample size and power calculation, and then next talk about study endpoint in brief. I mean, most of what we'll be dealing with here will just be the basic principles behind this. All right, so I mean, while calculating sample size, it's important to highlight that the kind of sample size formula that will be used depends on the study design or trial design that is selected. One common formula we'll get is the sense formula on the left-hand side of the screen. And basically, it's accounts for addition of significance level, which is the Z alpha, the power, which is the Z beta, and then the denominator, which is the effect size, mu1 minus mu2. Of course, the variance is the variance level is on the it's as numerator on this. To calculate the variance, really, variance is really square of the standard deviation. And in studies that has just one standard deviation, it can actually be selected and used in this formula. Now, one thing I would like to highlight, because some of the formulas might look similar, but what they calculate is different. That applies to the parallel group trial formulas versus the crossover trial formula. If you look at the next screen, the chose formula, I mean, there are different formulas for calculating sample sizes for crossover trial, but chose formula looks similar to the parallel group formula in terms of everything, but the computation it makes is the total sample size. Now, I earlier highlighted Z alpha being the significance level, and we'll see that usually we use 95% at 95% confidence interval. Significant level read up from table is 1.96, and 80% power, which is the minimum power that is used for most trials, read up from table is 0.84. For comparison of proportions, we'll see that we have to account for both proportion in the first group and proportion in the second group, and then subtract the proportion between the two groups in place of the standard deviation and the effect size in the comparison of mean formula. Now, this is a little bit different when you are looking at quasi-experimental study, because you won't see that multiplication by 2, because of course this is just a single group study, so there's no between group comparison, but a pre-post comparison. So in that regard, also delta, which would be an equivalent of something like the effect size, is subtraction of mean before and after the intervention, and variance, which was straightforward standard deviation squared, will in this case will not just be looking at the variance square, but also subtracting it by some factor. I'd just like to highlight, because one of the endpoints we look at in trials, especially drug trials, is survival. So one of our primary endpoints is looking at survival in clinical trials. We also need to base our sample size on that primary endpoint, and that will mean that we will need to look at previous studies on hazard ratio in order to get, on hazard rate in order to get the hazard ratio and compute into the formula. One of the commonest formula used is the Coinfield method. It's old and it's still being used, and What this formula actually calculates is not the sample size per se, but the number of events required to achieve that sample size. And as such, when this is gotten, we need to actually divide this by a proportion of subjects that will experience the event, say at a 2-year time point, in order to get the actual total sample size for the study. Now, just in brief, just to say that while calculating sample sizes for group level trials includes cluster randomized and step wedge trials. Will not just our sample size will be based on the earlier ones, either we are comparing proportion or comparing means in a parallel fashion or in a crossover fashion, or we're actually using survival to calculate, but we have to include the design effect because cluster randomized factor. Cluster randomized trial is done at the group level, and to calculate the design effect, highlighted is a formula for the cluster randomized trial, which actually includes the intercluster and correlation coefficient in order to account for this. And for step wedge, it needs to be more complex because we need to include both the design effect for cluster randomized trial as well as also include additional effects for design effect for step wedge trial. And this is where the number of periods we earlier calculated and the number of clusters comes in making this sample size calculation. One common thing we experience while trying to run studies generally or run trials is the fact that data is not available in the initial period because perhaps nobody has done something about it. And that's where feasibility trial comes in. And using a confidence interval approach to calculate sample size is really applicable in this case. What we just need to do is just to get the P, just estimate like a proportion you think will enable you to achieve a particular recruitment rate over a particular period, and make an assumption for the precision. Usually for moderate precision, 5 to 10% is assumed and of course converted to decimals. And we usually make these assumptions for at 95% confidence interval. And you see the next example on the next slide, how you can compute a sample size to be of this. For trials too, one needs to account for dropout, and adjusted sample size will be calculated based on dividing total sample size by minus the 1 over 1 minus the attrition rate. Yeah, just to highlight that some of these formulas are a little bit complex, and there are a lot of softwares online now to calculate this sample size easily. You just need to know the study design that is being used as well as the assumptions you are making in order to do this. GPower is a very good resource, and Melcalc also has an online software for this. Apart from that, there are various websites with validated sample size and calculators. Important to add a caveat that some of these online formulas also use variants of the formulas that I've earlier highlighted because, like I said, a lot of mathematicians and investigators, epidemiologists have brought out various formulas and computation estimates might differ. Particularly, I would just like to highlight on this slide another problem that happens while calculating sample sizes. We probably have the outcome measure, probably proportion for one group, but we don't have the proportion for the new intervention we are going to do. In this case, for instance, this particular example on the first bullet is on the cheetah trial we did some years back now. We wanted to look at the effect of changing surgical gloves and before abdominal wound closure and compare group that didn't receive that and group that received that and compare the SSI rate. So SSI rate, we already know for our standard of care, which is not changing glove before abdominal closure at 16%, but our new intervention was to change gloves and we do not know what the SSI rate for it will be. Really, for this type, which is common in most trials, we want to design newly that is innovative. We need to probably assume something that is clinically relevant difference we want to detect. So, for this case, assumption of a relative reduction of 25% in SSI rate was done, and this amounted to looking at reduction from control group rate of 16% to 12% when we look at change of gloves, and with it and other factors, our sample size was calculated. I'll quickly look at study endpoints now, and endpoints are outcome results measured at specified times during the study to determine whether the intervention compared to control group has provided benefits. And there are different types of endpoints. I've earlier talked about survival and highlighted biomarkers at some specific points during this presentation. Another type of endpoint is clinical outcome assessment, and this usually uses a clinical assessment instrument. It could be patient reported because, in this case, coming directly from the patient or clinician reported, being a member of the clinical investigator team, being the rater, or observer reported, which is by observations made, not necessarily by anyone specialized or the patient or performance outcome. In this case, is based on a specified task done in the study. Now look at just some examples of these. An example of patient-reported outcome is patient self-reporting pain intensity during VOC. Because pain during VOC can, be assessed by a physician himself, or patient can self-administer the NRS numeric rating scale on himself to assess it. So, self-reported pain intensity during VOC is an example. And the example is self-related quality of life. And there are various validated instruments as shown here, PIT-QL for the pediatric population, and ASCQ, adult sickle cell quality of life measurement information system for adults with sickle cell disease. In the same way, when we look at clinical clinician reported outcomes, we're just giving some examples here, a number of hospital admitted VOCs or stroke or tear incidents. It's important to know that while planning trials and highlighting endpoints, specific definitions of those endpoints must also be clear because, there are variants in those definitions between systems, between clinicians, between countries, and it's important to define so that other people that want to adopt or expand or scale up trials or repeat the same trials are able to adopt what is being done by you. Observer reported endpoints are highlighted, caregiver report of child's mid-school activities, observer report of sleep disruptions. It's based on what you really want to do. And there's really a tool to assess performance outcomes. There's this sickle cell disease functional assessment battery that can be used for composite functional assessments. Survival outcomes is one thing, and survival outcome does not necessarily mean death. It could also be, that's overall survival. It could be an event-free survival, looking at time until the patient, maybe from presentation until the patient develops some sickle cell-related complication, as we highlighted in one of the slides earlier, or hospitalization-free survival, infection-free survival, as shown here. Importantly, again, I must also say that all this needs to be specifically defined for the study. Biomarker outcomes as highlighted, and I'll just talk about patient engagement while developing a trial protocol. It's important to involve end users, and end users could either be the patient themselves, or caregivers, or clinicians, and or community, or the health system stakeholders. And important to look at all this because, for one trial, one particular set of stakeholders might be relevant, and for the other trial, that same set of stakeholder will not be relevant, but another might be more appropriate. But pretrial involvement is important, and part of the ways they can, these end users can contribute to trials is by looking at the study protocols together and quartering it, and this applies mostly to clinicians and perhaps some health system stakeholders or community stakeholders. We can also involve advocates or even patients in study advisory boards, and patients or other participants can pre-test tools. Sparkle actually developed a registry following some stakeholder workshops showing some evidence of some form of involvement in, end user engagement in trials. Now, this is important because there can be quite identification of relevant outcomes that really matches real-world practice, and then acceptable trial protocols, which will actually be feasible to implement, can be developed. And that will address practical barriers in the research. It also enhances the development of culturally sensitive study tools, And if you look at it, co-developing trials with the end users eventually helps strengthen patient recruitment because it creates trust during the process of the trial, because trust will have been built during the development of the trial itself. It also improves data quality because the degree of procedural adherence and data completeness is likely to be better. And the implementation, even after we finish the trial and we get evidence of effectiveness, is likely to occur and likely to be scalable and likely to be sustainable. In this last few slides, we'll talk about operational determinants of trials. We'll be talking about patient recruitment, patient retention, and conclude it with final aspects on data collection. We'll focus more on the practical strategies to enhance patient recruitment and involves, enhancing trial awareness, and that includes doing outreaches to relevant end users. It could be local community or religious houses for sensitization. Collaboration with patient advocacy group will also help in patient recruitment because they have a network. And digital recruitment can also a trial where a lot of people do, advertise trials on social media now or by emails or patients registered to their trial, on their trial registry. One other way to enhance patient recruitment is rather than using paper-based forms to actually physically look for patients in clinic, look at previous record of patients and put selection criteria on the EHR to rapidly flag trial candidates. And the actual trial registry now with an online tool, patients pre-registered on the trial, and one just needs to fill in an online screening pre-screening questionnaire, and it will be able to match candidates for whichever trial that is being planned. Patient enrollment can also be enhanced by not just being in a silo to recruit patients. One could talk to physicians to refer patients. And part of what can aid this is also translating trial materials into local study languages to enhance this, as well as also reaching out to places where ordinarily there are a lot of patients, but it's difficult to bring in those patients to the hospital by establishment of mobile units. Now for retention, we would say that it's important to retain patients in trials, especially for follow-up studies, by ensuring flexible scheduling. The trial doesn't have to occur on a weekday or at working hours. Study-related visit appointment can be fixed at weekends or evenings. Home visits can enhance this. And recently, people also do virtual visits to enhance some trial retention and prevent dropouts. Support packages, of course, also helps, and this includes reimbursement of patient for travel or compensation for their time. And it's important, especially for long trials with multiple follow-ups, to keep patients engaged by disseminating language newsletters and sending appreciation thank you letters to them at the end of the trial. I'll just briefly talk about case report forms. And case report forms is actually standardized forms used to collect trial data, and they can be paper-based or electronic. One of the most common electronic forms used is a red cap, and it has free registration for LMICs after satisfying some criteria. Others include Honor Kobo Toolbox. I know a lot of people use Google Forms, even though, for trials, you also need a secured database platform and not just an open access platform to store your data. And principles of design of these case report forms, like we said earlier on, involvement of various experts who will be relevant in providing key information that is necessary for the trial. The trial should also contain data needed to meet the endpoint and safety compliance. And it's important so that people will fill the data with completeness for the questions to follow a logical sequence, like, say, history, physical examination, investigation, treatment, or if one is looking at clinical workflow, pre-admission, admission, post-admission, and forming the long-term follow-up period. It's also important to clearly define the different questions one is used. It's not just enough to say perhaps you are collecting data on a middle palm circumference, but you need to define what middle palm circumference is. So that if any other person, because I mean, we can have data managers or clinical research coordinators collecting data for us, they know this and they follow the particular benchmark you've set. Close-ended questions are better because it facilitates easy conclusion. I mean, easy completion. And data management in case report, in using case report form is important. Before we actually use it, it's important to pre-test it to identify potential issues and correct it before deployment. And while doing data collection, it's important to have a data manager who regularly cross-checks the data, flags out inconsistencies. For instance, both data sets will collect date of birth and age, so that if someone makes a mistake in the age, it can easily be flagged out and corrected. So queries should be regularly, I mean, there should be regular checks and queries of collected data generated by the data manager and then disseminated to study coordinators at particular sites. So, in conclusion, designing a large clinical trial is rigorous. It requires knowledge, meticulous planning, and strong collaboration. Executing demands foresight, coordination, attention to detail. It's important to start early and invest the time the trial protocol deserves. There might be challenges, but it's important to stay resilient because with thoughtful design, the trial can achieve meaningful and impactful results. Thank you very much. So we can take a few questions if we have some time left.
Thank you very much, Dr. Tolani. Thank you very much. That was quite succinct. Regarding the questions, please, we'll take them at the end of the second presentation. A couple, I think some people have already posted questions in the chat while you were speaking. So you could be looking at that. It will be part of what we'll address once we are done with the second presentation. Thank you very much, Dr. Tolani. So we will move on now to the second presentation for tonight. We are going to hear from one of the regulators, a major regulator when it comes to clinical trials. So we have Dr. Beno Yakubu, who is a deputy director from NAFDAC, who will be speaking to us from the prism of what they look out for or what they expect as a regulator. So please join me and welcome Dr. Beno. And please, can the admin start off his slides for him?
Good morning, everyone. Again, like the moderator said, my name is Dr. Beno Yakubu, and I work for NAFDAC. I'm sorry I may not be able to put up my video because my network is not that strong, so I don't want it to disrupt the presentation. However, can we have the slides put up?
Yeah, please, can the admin, can you share? Okay, thank you.
Thank you so much. Again, once again, good evening. Next slide, please. My presentation is on site selection for clinical trials. Again, for every clinical trial, the site must be well selected. You cannot conduct a clinical trial without having a site that will produce the quality data you need. Again, so in the introduction, clinical trial preparation is a comprehensive process for planning, designing, and getting all necessary approvals and resources ready for clinical trials to start. And this involves creating a detailed study protocol, which outlines the study objectives, the method of this trial, participants' criteria, that is recruitment criteria, as well as need to ensure all regulatory, ethical, and operational aspects are in place, including establishing SOPs for the study. And again, key point of it is training your staff. Again, without trained staff, qualified staff, I think you may hardly achieve the aim of the study. The question you want to achieve, answer, you might not be able to answer them. Then we need proper site selection for all this to get a positive outcome of your studies. Next slide. So, site selection is a rigorous process in conducting clinical trials, successful clinical trials, and in compliance with the regulatory requirements. Again, without, like I said, without good site, you hardly achieve what you aim at. While choosing clinical trial sites, there are a number of factors that require careful consideration. But first and foremost, should always be the site's ability to gather high quality data, which is the key for every clinical trials. And also the site should have experienced and qualified staff, should have available and suitable patient population who meets the protocol entry criteria, then the ability to perform required clinical assessment. Again, all this selection is done by the person who sponsored the study. So for us as regulators, we want to see all those things being in place at the site. Again, because we know without that, compliance to regulatory guidelines and requirements might be very difficult. And again, we would want to see that happen, because at the end of it all, what we want to see is that we want to see credible data coming out from the site, as well as making sure that the patient participants are being taken care of. So without good site, you hardly achieve this. So at going to during inspections or whatever, we see these things that's supposed to be at site. Without them, we might be able to raise a question of red flags on that. Next slide. So site selection requires due effort on the part of the study sponsor to ensure that the proposed study site meets all the consideration for a successful clinical trial to be conducted. Like I said, this is done, the selection is done by the person who is sponsoring these studies. However, the sponsor might decide to delegate this responsibility to the contract research organization to do that for him or her. So again, we want to see this because sometimes they need to go to the site to verify what they want to see at the site before they could be able to pick those sites. We've had instances whereby sponsors come through us trying to ask us to give them some of these sites. But again, we find it difficult to do that, because if you recommend a site and eventually maybe at the end of it, it did not meet the requirements of what the sponsor wants, they may definitely say that NAFDAC is one that directed them to those sites. So again, it's a good thing that we have them do the selection by themselves, but making sure that those basic criteria are met. Otherwise, it becomes a problem when we are conducting site assessment of GCP inspection visits to those sites. Next slide. So there are some considerations in selecting sites, again, which is very critical if sponsors look at those considerations and make good site selections. Again, we always consider the experience and qualification of the trial investigator. You cannot divorce the site and the researcher, because the two of them are one. And in accordance with the GCP guidelines, the selection of principal investigators should be based on the education, training, and experience. Again, if you don't have that experience, I wonder what you will do when conducting the study, or if you are not trained on that protocol or on basic research principles. So, does the PI have adequate education, training, and experience? Which again, we ask during submission for approval. Those are part of issues we look at. We check the qualification of the investigator at that site to make sure that it is fit for the purpose. Then does that PI have adequate knowledge of the therapeutic area and clinical research regulations? Again, those are basic knowledge that we want to see, because there's no point if a researcher it's an oncologist and you're conducting maybe a malaria study. Again, we know that, yes, it could be a health professional, but then the basic knowledge of oncology, malaria might be lacking or might not be adequate. So we want to see a particular PI to be qualified in that area where he want to do the study. Then does the PI have the ability to conduct the study in accordance with the protocol and with minimal deviation. Again, PIs are very crucial, like I said, but then we look at all these criteria to make sure that the PI is qualified. That is why we demand for the CV of those principal investigators. Again, we've had instances whereby we get submission for multiple site studies where you see is investigator at a particular site. It's not a medical doctor. Again, somebody might ask, because we've had that deliberation with some scientists. The question they put forward is that, must a PI be a medical a physician? Again, yes, in other climes, they will say if you are versed in the principle of research. But here, I think we encourage all the peers to be medical doctors or physicians, because again, in this climate, they're the only one that are qualified to diagnose and treat patients. So we've seen such, and we encourage, or we advise the sponsor to make sure that the PIs are physicians who understand both medical ethics and research ethics. It makes it easier for compliance. Then PI must have effective communication skills with the study participants, sponsors, and its committees, as well as regulatory authority. Again, without knowing how to communicate, you hardly answer queries when the regulators or ethics committee are reviewing your proposals. So again, you must be able to address issues that are raised. So this is based on your experience as well as your training. Without that, it becomes difficult to have that smooth communication. We also have had that experience whereby it became difficult, that leads to longer time for approvals. So those are the issues that we need to see. We want to see a PM investigator qualified to conduct clinical trials. Then again, the experience and a qualified monitor. Monitors are very crucial in the conduct of clinical trials. For every site, without a monitor, it becomes so difficult for them to have proper compliance to both guidelines as well as regulations. So with the monitor in place, a qualified monitor, an experienced monitor as well, we have seen sites easily comply to let down guidelines and rules. So a monitor must have a scientific and clinical knowledge of the protocol, GCP, as well as regulatory requirements. Again, that is very crucial, because he will be able to guide the PI. Again, remember that monitors stand as an eye for the sponsor. So he makes sure he make all those corrections, make those adjustments, draw attention of the investigator to what is doing outside the protocol or any other deviation or violations. He correct that, hoping that the PI will be in right perspective when regulatory inspectors come to inspect the site. Then the monitor must have monitoring skills as well, such as ability to verify trial data accuracy, completeness, and compliance. That is very crucial. So without a good monitor, you may hardly meet up with your compliance. Again, without proper compliance, it affects the outcome of the study. It might delay the study completion timeline. And again, it might attract regulatory sanctions when you don't have good monitors. And the monitor must have good communication skills to help smoothing conduct of the study. Again, that is the only way he can do to assist the site conducting smooth studies. Monitor must have been trained and have the experience in clinical trial monitoring, GCP, and regulatory requirements. I think I've said that. Then must have problem-solving skills, such as addressing issues, including protocol deviation and adverse events. Again, we also have had experience whereby maybe the investigator didn't know that he's supposed to report serious adverse events. Again, on proper investigation, we found out that the study had no monitor. And again, going to the site, we discovered that a lot of non-conformances were being found in the course of the study. That really delayed that clinical trials, because a lot of queries were raised, and it took time for the site to be able to address those queries, and the study continued. Next slide, please. Then the site should have experience and a qualified study coordinator and other study team members as well. Again, study coordinators are very crucial in the lifespan of clinical trials, because from the beginning to the end, they are up and doing. Again, without the PI on site at that moment, it's their responsibility to make sure that every aspect of the study is being coordinated very well. So this study coordinator must be qualified by training and relevant in relevant fields of science and healthcare administration. Again, it must not be core scientists, but if you have qualification in healthcare administration, I think you can qualify to be a study coordinator. Again, this is very crucial because every aspect of the study is under the purview of the study coordinator. Sometimes, most of the times, he guides even the investigator to see what the PI has not seen. Then CTC should have knowledge of GCP and regulatory compliance as well as the study protocol, which is very key. I think he must not only have knowledge, but he should be able to talk about the study protocol, not without reading it. He should know it offhand and can be able to do anything that the study protocol says. So if he sees any deviation or any violation without going through the study protocol, he's already know that, look, study is going out of the protocol and he can correct it. So he runs the day-to-day activity of that particular study. So each site must be able to have a study coordinator in place. Then there are a lot of, it must be certified. There are a lot of courses, certified courses, that is advisable that study coordinator should have. And again, at the point of inspection, we'll look at this qualification of this study coordinator as well as that of the PI and the monitor, because those are the key people that run clinical trials. So there are a lot of certified trainings, like you could see here: certified clinical research associate training, certified clinical research coordinator trainings. These are certified trainings that we advise CTC to be able to go through them, so that we know that they are qualified to do what they are doing to run the site very well. The coordinator should have skills in problem solving, because again, a lot of issues might arise during the conduct of the studies, and he should be able to be there. When you have lost a participant, he should be able to know how you will try to see how you can trace these participants and find him. Look at when you are having so many much attrition rate, he can be able to look at the way of finding a way to see how he can mitigate that. He should have previous experience in clinical research coordination in a related field. That will give him an edge in running a site very well. Again, with the added knowledge of the trainings, he can do better. He should have the ability to work independently, because it's a huge task. Without the PI, without anybody, he can be able to coordinate the sites as when due. He should be multitasking and problem solving as well. CTC should have excellent communication and interpersonal skills, because you deal both with the participants as well as the other team members. You should be able to guide them to do their specific roles. Otherwise, they might deviate from their roles and responsibilities. So we need a well-trained and well-experienced coordinator to coordinate clinical trials. So it's pertinent that each site should be able to have a clinical trial coordinator at each point in time. Then we look at geographical location of the site. Again, this is very important, because when you have a site located where it's difficult for participants to be able to have access to it, again, the aim will be defeated. So that is why it's very important that the site should be situated in an accessible location for study participants. And there's need for the study visits to be decentralized. This will really bring participants, the study closer to the participants. Otherwise, when it becomes so far for the participants to get there, again, they get discouraged. So in selecting site and in putting a good site, you should consider all these points, so that again, you'll be able to conclude your study as when due. Because there's no point you start the study and again, you stop along the way because you didn't have enough participants to run the course of your studies. So there must be measures put in place to lower premature dropout rates due to distance. Again, with much distance is discouraging. Remember, they are not coming there to be paid, but again, just to be able to compensate them. But if they have so much activities and the site is far, it becomes difficult for them to be able to comply to their visit dates. Next slide. Then you anticipate the rate of participant recruitment. Again, in each site you want to select, should be able to know, have it at the back of your mind that there's possibility of you getting enough participants to run the course of the study. So you know that you should be able to ask some questions such as, does the site have constant engagement with the host community? Again, that is where the issue of community engagement comes in. I know some sites here in this country that have that robust community engagement whereby at every point in time, they have communities that if they get studies today, they can easily go there to recruit their participants. So that should be in place. Look at sites that have those kind of proactiveness. Those decide to have collaborative approach with advocacy groups. Again, some sites do have that, whereby they help in mobilizing participants to be able to key into the studies and be able to allow you to get what number of participants you desire to have in the study. And again, the site should be culturally sensitive. Remember that each community have its own specific maybe culture. Then you should be able to key into that so that you'll be able to encourage them to participate in your study. So in looking at selecting a site, those are issues maybe sponsors should consider. And again, this really helps to drive the studies to completion within a stipulated time. Then you consider the timing of ethics review, board meeting, and approvals. Again, the site PI or the site particularly should be able to know or be familiar with ethical guidelines, where and how to submit your applications. Should be able to be familiar with the review process of an ethics committee, so that if ethics committee meets maybe twice in a month or once in 2 months, you should be able to be familiar with that, so that you would not have your study being delayed in the course of approval. Then look at the turnaround time for ethical approval. Some ethics committee takes more than 1 or 2 months to approve studies. So look at those timelines to be able to guide your planning in the studies. Then contractual agreement, again, are part of things that selecting a site you should consider. Again, and the budgetary negotiation. Again, sometimes in the course of your agreement between the site and the sponsor or with the PI, there could be lapses. Again, these are issues that for sponsor to select sites, you should look at consider those things. Again, we've seen some negotiations or some agreements that we doubted it because you find out that there are some responsibility that the site administration will say no. What I mean by site administration may be a hospital. They may negate some responsibility, which you know, if that continues, will affect the conduct of the study. So those are the issues that whosoever is selecting sites should look at it very carefully, so that there should be understanding between the sites and the sponsor, or between the sponsor and the PI who is going to conduct the study at that site. And the sponsor should be careful with conflict between sponsor and the site contract terms to minimize delays. Again, when there's delays in signing contractual agreement, it affects the whole lifespan of the study. So those are issues should be considered in your site selection before you pick a site to conduct clinical trials. Next slide, please. Then site regulatory compliance history. Again, you look at the site, if they had studies before, what has been their historical background? in compliance with regulatory guidelines or with ethical principles during the conduct of the studies. There could be some sites that during the conduct of the previous studies have had many regulatory issues that they were unable to meet up. They were able to respond. Again, you know that putting this site, selecting this site will be a problem potentially. So again, you look at those history and be able to work around it to make sure the site it can deliver what you want it to deliver. Because for every clinical trials, there's budgetary allocation and it's time bound. So with an extension, that will really add into your budget. So you look at the record of violations or no reporting safety signals or no submitting progress report to regulators. Regulators will flag them. So they will communicate them or send warning to those particular sites. And for us, because we know some of these sites, we categorize sites based on their potential risks. There are some sites today, I close my eyes to say, okay, we know their compliance history. They can comply, they comply to most of the study they've conducted. And there are some sites we know that they're of high risk. Not all type of clinical trials can be conducted at those sites. So those are the issues that anybody who's selecting sites should be wary of, because you might get into a site that may not give you what you desired. So you look at the regulatory turnaround time, know the regulatory guidelines and requirements, know the regulatory approval timelines, and know the site response to regulatory queries. Again, during the course of your clinical trial application process, there could be queries that goes back to the investigator at the site and how long does it take to respond? Or the site could look at the response rate as regards to the number of queries issued to that particular site. So again, you need to look at the track record of the site with previous clinical trials that are similar. Look at the regulatory compliance history of that site and the PI's compliance history, how they adhere to regulatory requirements. Look at the site's audit performances in previous studies. Have there been many non-conformances? Have they responded to queries as submitted by the regulators? How the site responds to CAPA issued after audit? Have they responded to corrective action and preventive action adequately? Have the audit been closed based on their responses? Then how the sites adhere to previous protocol and procedures? Again, protocol adherence is very key and very important. Many deviation in clinical trials shows that the site is not prepared, or many violations shows that the site is not prepared in terms of maybe staff training or adequate resources to be able to conduct these studies. So whether the site have robust quality assurance process and can demonstrate commitment to quality, this is very key. Do they really have those things in place? Do their quality control, quality assurance in place so that they can be able, you can be sure that what they will generate out from that study will be robust and will be credible. So without those things in place, again, you should doubt the site's capability of handling a study. Next slide. So again, adequate facilities, it's very crucial. Adequate facilities in terms of availability of specialized diagnosis or therapeutic equipment required for that protocol. Again, those entails maybe the person who's going to select the site, the sponsor, to visit those sites and see whether they have this number of equipments that can run the study. Again, those are some of the advantages some sites do have, because some robust sponsors may decide to say, okay, we're supplying these equipments for the purpose of this study, and those are the benefits that sites stand to gain. But again, they should make sure those equipments are in place. There's no need for them to improvise. Again, those are the issues sometimes we discuss with the PIs. If you don't have those equipments, cry out to the sponsor. Tell him without those equipments, it will be difficult for you to run the study. Don't improvise. So every sponsor should be able to make sure that the site should have those required equipments to run the study based on the protocol. Adequate space and storage conditions, including archiving space, is very important, where you keep your archives, your records archives your even your IPs. Keep your IPs, adequate pharmacy store, adequate cabinets to archive your data. Then available resources in support of in support departments. Other support departments need to have adequate resources. You talk of the data room, data entry room, talk about even the consent room, all other supporting departments. The lab should be very well equipped for that study. Sufficient space for participants' visit, procedures, and data management. All these things must be in place to qualify a site to be a better site for clinical trials. Data management capabilities, which includes electronic data capture system to ensure accurate and efficient data collection, should be in place. I think that is where everyone is going to now. So if a site do have this, it gives it an advantage over other sites. The site should have procedure in place for quality control, quality assurance, and auditing to ensure compliance with GCP and regulatory requirements. We've mentioned that before. Then availability of a suitable patient population. The sponsor should ask what strategies are in place to identify patient eligibility. Again, using advocacy groups, participant engagement or community engagement is key in making sure you get available and suitable patient population. Is there a correlation between the subject population and the disease or condition under study? These are the issues you look at in selecting site. If they don't have enough prevalence of such disease in that community, there's no point for you to go there to pick sites because it's going to take you longer time to be able to get the qualified participants to run in your study. Make sure that the trial population mirrors the target population in terms of age, sex, and ethnicity. That is very crucial in site selection. Next slide, please. So, those are the considerations that a sponsor should look into before picking a site. And again, for us regulators, we want to see this in place because when you get on site, you have all these considerations are taken care of. Then it makes the study more robust. It makes the inspection easier for us, and compliance it's better. So, clinical trial site is a physical location where trial is conducted, where the PI is the physician or other qualified healthcare professional who leads the trial at the site. So the PI is ultimately responsible for ensuring that trial is conducted ethically, safely, and in compliance with protocol and all regulations, overseeing the research team and managing the study's day-to-day activities at the site. So you cannot divorce the PI and the site. Without a good PI, site might hardly be managed well, and that will really affect the overall conduct of the clinical trial. Next slide, please. So the success of clinical research highly depends on the performance of a selected site with qualified and experienced staff. Careful selection of an investigator helps in proper site management. Next slide. I think that's the last slides I have for tonight. Thank you very much. I expect questions.
Thank you
Over.
very much, Dr. Beno. Thank you. That was quite practical. So we've come to the Q&A part of this session. I think we should start off looking at the time. Let's start off with some of the questions that have been posted online. Dr. Tolani, there were some questions online that were extracted and forwarded to you. Please, I think you should start with those ones.
Yeah, so I'm happy to respond to them. One of the questions is, if you send thank you notes at the end of the trial, how useful is it in subject retention? I mean, is it not better to send those notes after every follow-up? One thing we need to do in trials is to also ensure that we are pragmatic enough and not impose difficulties on either our staffs or even the patient itself. And then as such, I would think it's much more impractical to send after every follow-up. Now, if you look at it, end of trial might not mean the end of the entire trial itself, because trial has like an intervention phase, and then some other trials includes a follow-up phase. If you look at it in that perspective, to keep engagement, it's important to thank your patients after you finish the intervention, and you might want to follow up for 1 year even after delivering the intervention. So in that case, at the end of the intervention phase of the trial, it's important to like send some thank you notes, and then that might help engagement in the long-term follow-up period for patients. And again, even if you don't have a follow-up phase, you also, I mean, we might also need to engage those set of patients in future trials on a related question. I mean, sending thank you notes at the end of the trial can also help for future engagements. Now, okay, looking at the second question here, how do you make sure that your trial is not underpowered by manipulating the attrition rate? First of all, I mean, once you've calculated the powered sample size, at least the minimum sample size. I'll give an example. Calculated totally that in your center, when you say you want to recruit at least 100 sickle cell disease patients, after 1 week of intervention, I mean 10% drops off. That means effectively you're only going to get 90 patients being included in the study, and as such, you need to factor in that attrition rate to make sure at least your study is minimally powered for the study. So I mean that's how you look at it. So I wouldn't really call it manipulation per se, but adjusting your sample size in order to meet the powered sample. What level of participant retention is considered acceptable for the result of a clinical trial to be valid? I mean, most people use 80% anyway, but I would say it really varies, because if you have a short follow-up period like 1 or 2 weeks, you might be looking at up to 90%. And if you're having a very long follow-up, of course, the longer the follow-up period, the longer, you have more proportion likely to have attrition. So you might probably want to skew below 80% to like 70%. However, I've not seen any attrition less than 70. I mean, retention less than 70% being considered very successful. Let me see if there's any other question. So is ethical approval needed for a pilot study? For me, I would say for any human subject research, you really require ethical approval. Perhaps if there is some secondary data collection, you still need to request for some exemption from ethical approval from the HREC, or if it's an audit, I mean, based on your local institutional policies. Those are the questions I can see. Thank you very much.
Thank you very much, Dr. Tolani. Thank you so much. Dr. Beno, thank you. There were some comments on the chat regarding support from sponsors, and at the end, they want to like come and take away the whatever support, infrastructural support they've given to the sites. Professor Nodu noted that sadly some of the sponsors will come and request that the equipment be returned back. In fact, even things like laptops that they presented with some software for use, they will want it back. Is there a way regulators can like sort of do some, I don't know, capture it in such a way that sponsors or CROs will know that those kind of support should not be taken away? Because when it's the sponsor against the sites, it's difficult for you to insist. Yeah, Dr. Beno. Hello, Dr. Beno.
Hello?
Okay.
Sorry, I think I was muted. I was unable to unmute myself.
Okay.
Again, I think I'm so surprised that at the end of the study, sponsor will come back to request for return of the equipment used for the study. I think that was the first experience I've had. Well, Prof said that the sponsor came back to request for the return of such equipment. Again, it's to me, it's not ethical enough to do that, because remember, those are the equipment that really help you to generate what you wanted to generate. So I think to mitigate this, maybe at the point of negotiation, you should be able to be very categorical. This is what you lack or you don't have, and you want them to provide such. I don't know where regulators will come in here, but I think that can be mitigated at the point of negotiation. I've seen sites whereby the sponsor demands that they will provide this. They said they must provide this equipment to run the study, and that is one of the benefits that the sites get for conducting such studies. That's one of the benefits that the institution gets as well, not only the monetary aspect of it. So I think that I suggest will be more stronger if you capture it at the point where when they want you to run the study for them. So, but as for regulators, I think those are issues maybe we'll table at the managerial level to see what we can do if we can assist. That's what I can say for now.
Okay, thank you very much. There was also a request that I guess about when you were talking about clinical research organization certifications and clinical coordinator, clinical trial coordinator certifications. Someone requested that if you could provide links for reputable organizations that can.
Oh, there are so many of them. Maybe
Yes.
I can do that.
Yeah.
And
Then we can
on the
share
WhatsApp
it.
chat.
Yeah, we can share it later on, maybe at subsequent.
Yeah, I'll do that on WhatsApp chat.
Okay. Thank you
Yeah.
very much. We are 3 minutes to time. I can't see any other questions. Please permit me now. I'll call Professor Nodu to please close the meeting for us. But before then, please just to tell those who have been asking for these presentations, we have stated clearly that we will be sharing the links for the recordings, and those links are there at the SESTA website, and the admin would share, okay, yeah, even on the chat now, the link to the previous recordings are there. So once you go into, or even if you just go into the SESTA website, you would see, just Google SESTA, you would see the link for the website. I will share the link to the website now as Professor Nodu is closing, so that you can go in there and you see the advertisement for this clinical trial. Once you click on it where it asks find out more, it will also take you to these recordings. But the chat in the chat box now, the recordings are there. It is the recordings that we are sharing, not the slides, please. But the recordings contain everything that you need, because there are additional things that the presenters talk about when they are doing the presentation that may not be in the slides. So it's the recordings that we are sharing, and you can watch it again and again and again for those who've been asking for it. Professor Nodu, please,
Okay.
over to you, ma.
Yeah, okay. Good evening, everyone. Good evening, Dr. Beno. And thank you very much to you and Dr. Tolani for these very exciting presentations. I also want to thank Katie Graff, BVGH, and our sponsor, Equivia, for another interesting set of presentations. I want to thank all the participants. You continue to come in your numbers and stay engaged. We are all learning a lot. And we hope that at the end, we will all be prepared to participate in more and more industry or even investigator-sponsored clinical trials. Thank you so much, and God bless you. Okay.
Thank you very much, Ma. And thank you to everyone. See you next week. Good night.